Very much for inviting me, thank you very much for being here. My name's Mike, I'm a paediatric neurologist, and actually I did meet Archie quite a little bit at the end of his time when he was on the Reed Neuromedical ward, and actually he was pretty inspirational even then, actually, because our teachers are getting very stressed out by Archie, because he kept asking for more work, and they didn't really know how to deal with that. So you've even impressed them, so well done. So I'm looking at, following on from what Ennerton's shown, is sort of like, we're interested in looking at infection, but I'm also interested in looking at brain infection because I'm a neurologist. And one of the problems about brain infections is that you've got two hurdles to get over. One, that you've got to recognise as an infection. Two, usually we've got to find another test to prove that infection, and a blood test isn't always the way that you do it. And that becomes a problem, and I'll try to explain why. I'm also entitled this course, Do You Wear a Pink Shirt? And that's because I work with neurosurgeons, and often the way that I identify them is because they wear one of the best shirts in the whole of the Alderhay. And I think we all work in a similar sort of way of using markers in order to identify and make judgments about people, or indeed about their specialities, and so that's the same thing, we're going to use markers to try and identify disease. So in the top corner here is a guy in a pink shirt, which happens to be me, and in this case we're doing a lumbar puncture on a child in Indonesia. And a lumbar puncture is the gold standard, currently the gold standard for looking for infection. But one of the problems of that is it's actually a really hassle to do. First of all, you've got to recognise that you need to do the LP, then you need to get a lot of things in place, and what's missing off this photograph is a large trolley with various bits of equipment and paraphernalia in there. And then what you need to do is enable to get the patient to lie still so that you can do the LP. But unfortunately this child was 17, as you can see he's quite burly, he was confused, and actually the most important person in all of this was the guy here who managed to calm him down and hold him still. And actually it's very hard often in neurology to try and get that sort of cooperation, both in paediatrics and in adults, and so doing that LP has got an additional roadblock to it in the fact that people are reluctant to the LP because you have to get things in place, you have to get staff in place, and that introduces more delays. And as shown by Archie's talk earlier, a delay can actually cause problems. And so we need to try a way of getting rid of that delay. So what I'm trying to do is trying to think, well, is there a way of sort of accelerating and encouraging us to get that LP done more quickly? And one of the ways that is using the blood test. The blood test isn't to get rid of doing the LP, but it's to try and encourage people that we really need to get on and do this, despite the difficulties of doing that. So currently, you try and find pathogen in the CSF, which is the blood surrounding the brain, and that can be difficult, particularly if you can't do the LP, but even if you do get the LP, you need to get a large amount of fluid from the cerebral fluid in order to get the test going. And again, particularly in, if they're moving around, it's difficult to get a large amount of fluid. In children, you often worry about the volume of that fluid, and that all makes it more difficult to get a good test. If you don't get enough sample out, that's another problem. And again, that's why it's useful to think about doing blood again rather than CSF. And if you don't get enough fluid out, then it can give a false negative, because you just don't have enough raw sample to find that bug. And then if you look at other parameters, such as the protein or the glucose, and as we've been described by Archie again, glucose can be a good marker, but it all can be non-specific. It can be due to lots of other reasons as well. So they're not necessarily the most discriminating parameters. So we've tried to look at a biomarker akin to what Ennerton described before, which is quick and easy to take, that encourage you to do a lumbar puncture. And the principle is based on host markers that can either be red, if it means they're going up, or green if they're going down. And at this point, if you're colourblind, I'd relax. And what it's like the game that you may have well played with children or with your child yourself, is that you're trying to find something that discriminates that particular baddie, and that baddie's the bug. And in our case, you don't use what their clothes they're wearing or what hair they're wearing. You're just looking at a pattern of those markers and then see if that helps tell you whether the host response is linked to a particular infection. And in the body, your white cells change depending on the response to whether it's a virus or a bacteria, and the pattern of these genes switched on changes. And so we're using to see whether we can pick up a particular pattern that helps you. So this has been very much helped by the fact that we have a study called Meningitis Northwest, which initially it's been done by a Liverpool Brain Infections Group led by Dr. Fiona McGill, and we're looking at patients, adult patients that have meningitis, either bacterial meningitis, they've got a bacteria in their CSF, viral meningitis, that we've got a proven virus in their CSF, or meningism, which means that they have lots of symptoms. They complain with the same symptoms of a headache, not liking bright light, feeling that their neck is a bit stiff, but when we do the lumbar puncture, we don't find any white cells. So that suggests that all those symptoms are not due to infection. And we're adding those in because it's a real life thing, and what we want to know is have a test that works where you can distinguish between those that have symptoms like it, viral meningitis, or indeed bacterial. And so this initially started off just around the northwest, but it's now gone to Meningitis UK, and we're now running 61 sites across the UK to get these samples. So what you can see from this is that there seems to be some markers that are up in bacterial meningitis, that's making it red. These are down in viral meningitis, and conversely there's some that are up in viral meningitis that are down in bacterial. So you've got something that discriminates between bacterial and viral, viral and bacterial. The downside is along here, the number of genes is over 500. And at this point, that isn't really a useful, tractable test that can be taken to the NHS. So we need to find a way of reducing it down. So what we've done is we've used various algorithms to try and find the best markers, and in this way we've been able to get down to 10 that gave you 100% sensitivity of identifying bacterial meningitis and 75 specificity of saying it's not that. And so that's based on array. But again, an array is it's mainly a tool of research. I think it's been used occasionally in the States, but really it's not used in patients. So we still needed to try and find a better way of doing it. So we tried another platform of just using RT-PCR. PCR is used routinely in microbiology labs. It's used for detecting bugs. And so we've used markers of the host response in PCR. And we got it down to 4 genes to try and differentiate. And a ratio given by those 4 genes makes it bacterial meningitis. If it doesn't hit that ratio, it's either meningism or viral. And this is very good, but obviously we're not that impressed, to surprise, because it's duplicate samples of the same ones on the array. So you're going to have a degree of overfitting at this point. Then we went on to do an independent sample set, so we got another lot of samples, 102 in total, where 10 of them or 11 of them were bacterial, and 88 of them were something else. And the reason why we kept that balance is because the test is based on a real life scenario. And so that when we get these patients, these patients coming through intensive care or from A&E, typically it's 10 in every 100 where we're thinking about bacterial meningitis, and the rest are meningism or viral meningitis. So we're testing in that ratio, so it's a real life scenario. And what we get from those 4 markers is increasingly we get a similar sort of thing, that we get 84% sensitivity and 74% specificity. Now at this time we were working with Fast Track Diagnostics on a separate study, and their chief executive, Bill Carman, who's also a professor in microbiology, or used to be in Glasgow, got interested in this. He thought this was vaguely interesting. But in a true sort of industrial way, he said, well, 84 sensitivity is not bad, but I don't think it's going to sell any kits. So he said, can you improve it? So we went back. We didn't have any more samples because we've used all we have in our sort of 3 years of collecting, because meningitis is relatively rare, and that sort of emphasises the importance that we need networks in order to get big enough numbers of samples. So we went to what was available in on the web. And so we had additional sample sets that we'd done previously, and we also looked at other sample sets that are freely available called Gene Expression Omnibus. And so using that, we were able to sort of go back and try and find additional markers. Again, this has been shown before in other infections. This is in TB, that you can find markers that identify between TB and others. But again, the problem is that they need 254. So again, we're trying to get it down into something more reasonable. So we've worked through it, and we've tried to get better marker combinations and then move to PCR. One of the problems we found is you can have markers that are very good in arrays, but when we move to using a platform of PCR, they don't work as well. So this is an example. This is gene A, and it shows very nice discrimination between bacterial meningitis and others. Gene B, same as shown. But when you use exactly the same genes in exactly the same patients, we get a massive overlap in PCR. And we think this is because there's differences in this platform and how it works, and we tried to get statisticians involved to try and work this out, and currently we're using a really technical technique called suck it and see, because we can't find a reason. If you get a mark that looks good here, sometimes it'll look like that, sometimes it'll stay. And going through that, we've now got 6 marker combinations, or 9 markers, and that gives us 90% sensitivity or 74 specificity, and so that's getting more towards what Fast Track Diagnostics wanted. And now currently where we're at is we've got 10 marker combinations, or 12 markers that give us 100% sensitivity and 71% specificity. So at the moment, the downside of this is it's not blinded. We've had to sort of develop these markers, and so we need to repeat this in an now independent set. But we're now in the sort of area that FTD would be interested in. The other advantage is the fact that, as we said before, Disease is a lot about, nowadays, unfortunately, not just about saving lives, but about economics. And the advantage of this is that if you have a test that helps diagnose meningitis, or indeed tell you to rule out it, that's got a big economic impact. And one of the problems that we see in our additional work in studying meningitis is there's a lot of perseverance of diagnosis, in the fact that once a doctor has decided this is definitely viral meningitis, this is definitely bacterial meningitis, we find that teams continue down that sort of diagnosis and don't change away from it. And there's the advantage of a test that it gives them a kick to say, well, are you sure that this diagnosis you made a couple of days ago is still bacterial meningitis or still viral meningitis, despite the fact that the CSF didn't really go with that, despite they're not really improving on antibiotics? Do you need to think again? And so the advantage of our test is it gives you that kick to think again and maybe rationalise your treatment. And looking at our groups, quite a lot of our patients with viral meningitis were on antibiotics, although they didn't have the confirmed bacterial meningitis. And then there was quite a lot, smaller number, but there were some that were on not on any antibiotics, but actually did have bacterial meningitis. So it's going to rationalise that care, and it can help sort of reduce costs from that point of view. So our next steps at the moment is we're trying to build closer links to fast-track diagnostics. We've provided the markers and marker combinations, but as we've seen, we've hit a sort of wall in this knowledge of translation between gene expression and PCR, and their expertise in developing best primers and also in developing multiplexers, because again, we want to come down, even if we're at 12 markers, that's still a lot to run. So we need to condense that down into a couple of tubes to make a test more available again. So now working on making multiplexers. At the best they're doing at the moment is they can do a 6 multiplet of markers in the tube, and at the moment the downside is that isn't quite as sensitive as when you do it individually. So they're trying to improve that at this point. And we've gone through Business Gateway and we have secured permission to file a patent. So as a beginning, I mean, it's not saying we're near to something that's going to go, not like anything's going towards patient point of care, but it's sort of, it's a healthy start. And the other thing that we need to do is continue to develop networks and continue to develop clinical collections of samples, because meningitis is a very rare condition, and in order to have enough samples to test both our particular biomarkers and other kits, we need to develop bigger numbers of these networks so we've got samples to use as that precious database. What we're also trying to do is expand beyond meningitis. We're thinking about, we work with the neurosurgeons in the Alderhay, where they're looking at studies of shunt infections. So when you have tubes in your head to drain off excess fluid, these shunts can get infected because they're like plastic and bugs like plastic. And again, we're trying to see if the biomarkers will work for that. And we've only done it on a couple of samples so far, but our 3 samples that we tested it in was good in the fact that the one that was infected had a similar sort of range to bacterial meningitis, and the 2 that were uninfected didn't. And so we're also trying to do it overseas, because there'll be bigger numbers in places like Nepal. They have a large, high proportion of patients have particularly encephalitis. The downside of that is what's wonderful about the NHS is they have a much cleaner diagnostic. Because we're able to relate closely to microbiology, it means that we can get a clear diagnosis on whether these are definitely bacterial meningitis, definitely viral meningitis, or meningism. The downside in Nepal is we get a much bigger proportion of those meningism ones, or possibly bacterial meningitis. It's not as clean. So though there's advantages about working abroad, there's certainly also big advantage of working in the UK, because we have an integrated clinical system with good diagnostics already. With that, I say thank you very much, and I hope you keep networking.